Welcome to the Deep Dive. This is where we take your sources, research papers, notes, articles, and really boil them down for you. It's your shortcut to getting properly informed, maybe finding some surprising things along the way. Today, we're diving into something really important in performance animals, something that, well, often goes unnoticed until it's a real issue. We're talking about equine tricuspid regurgitation, TR for short. Basically, it's a heart condition, a leaky valve.
And that's precisely the challenge, isn't it? Especially with these incredible equine athletes, telling the difference between a normal variation, maybe even something the body does because of training, versus a genuine pathological condition. That's crucial. So today, we'll unpack TR, from what it is to diagnosis, treatment, and what it means long-term for the horse. It's definitely got layers.
Okay, let's get into it then. Leaky heart valve. Sounds serious, right? But you're saying with TR, it's maybe not always a huge red flag. What's actually happening inside the heart?
Right. So the tricuspid valve, it sits between the right atrium, the top chamber, and the right ventricle, the bottom chamber on the right side. It's meant to be a one-way door. TR happens when that door doesn't close tightly when the heart contracts, during systole. So instead of all the blood getting pushed forward to the lungs, some leaks backward, regurgitates, back into the right atrium.
Okay, so normally, let's picture this. Deoxygenated blood flows into the right atrium. The heart relaxes, that's diastole. The valve opens, blood fills the right ventricle. Then systole. The ventricle squeezes to pump blood to the lungs, and that valve needs to slam shut completely, so all the blood goes forward. That lub sound we hear in a heartbeat, that's the sound of the tricuspid and mitral valves closing, right?
Exactly. That closure is critical for efficiency.
So at TR, that lub might be followed by, well, leak sound because the door isn't fully shut.
Precisely. A murmur often develops.
Now, this is where it got really interesting for me in the sources. How common is this? The numbers, especially for athletic horses, they're kind of startling.
They really are. If you look at, say, healthy middle-aged horses generally, maybe about 1.1% might have it found, incidentally. In the UK, that was one study. But then you focus on the athletes. Flat racing thoroughbreds. Suddenly it's 22%.
22%.
And then jump racing thoroughbreds, it jumps again to a pretty striking 43%.
Wow. 43%. That's almost half of jump racers.
It is. So yeah, it's reported most often in athletic horses. It's definitely not rare in that population.
So for you listening, if you work with performance horses, especially jumpers, this is something you're, well, quite likely to come across. But does finding it automatically mean problems? Is it always a big deal?
That's the key point, really. Very often, TRs is just an incidental finding, found on a routine exam, maybe a pre-purchase. And frequently, it has zero impact on performance. The significance, any clinical signs, it really depends on how much it's leaking and why it's leaking. Mild cases, usually no symptoms at all. But in more significant cases, you'll hear that murmur during the physical exam. It's a systolic murmur between the lub and dupe, graded usually 2 to 6. You hear it best over the tricuspid area, right side, around the fourth rib space. Although, interestingly, about 30% of horses with tricuspid infective endocarditis, that's a serious valve infection, they don't have murmurs, which is tricky.
That's a complication.
It is. And with severe TR, you might see other signs, things like visible jugular vein pulses in the neck, maybe some swelling under the belly or chest, that ventral edema.
So why should you care? Well, even if it can be incidental, understanding TR, especially in performance horses, is just vital. For their performance potential, sure, but also for their safety and long-term well-being. It's about knowing when that incidental finding might actually matter. Okay, so we know what it is, and that it's surprisingly common, especially in athletes. Now, the big question, why? What causes this valve to start leaking? It's not just one thing, is it? The sources point to a whole range of possibilities.
No, exactly. It's definitely not a single cause. Fundamentally, it just means the valve leaflets aren't closing properly. Coapting is the technical term. And that failure can come from the leaflets themselves or the fibrous ring they attach to the annulus or even the little muscles and cords, the papillary muscles and chordae tendineae that kind of anchor them. So let's break down the common causes. One of the most, interesting ones for this audience is probably physiologic TR, training-induced TR. You see this a lot in racehorses, thoroughbreds, standardbreds. The idea is that intense, sustained exercise, the high cardiac output needed, can actually cause the tricuspid annulus, that ring, to stretch a bit, dilate. In many ways, it's seen as just a physiological adaptation to being a top athlete. But if it stretches too much, it can become pathological, cause significant leaking.
So the heart literally adapts to the demand, but sometimes adapts a bit too much.
Kind of, yeah. And importantly, the chances of seeing it and how severe it is tends to go up with the horse's age and how hard they're training.
Fascinating. What else?
Then you have degenerative changes, just sort of wear and tear on the valve tissue itself. Things like myxomatous degeneration, cellular infiltration. Basically, the valve gets thick, distorted, doesn't seal well. This is usually slower, progressive, often linked more with aging.
Makes sense, like joints wearing out.
Exactly. Then, much more serious, is infective endocarditis, a bacterial infection on the valve. It's actually rare on the tricuspid valve in horses, thankfully. But when it happens, it's bad news. High risk of infected clots breaking off, traveling elsewhere, systemic embolization. And it can cause severe heart failure.
And you mentioned a link to jugular catheters sometimes.
Yeah, sometimes there's a history there. It can be an entry point for bacteria into the bloodstream. Then there are myocardial diseases, problems with the heart muscle itself, cardiomyopathy, where the muscle's weak, or myocarditis, inflammation, maybe from an infection or nutritional issue. If the ventricle muscle isn't working right or changes shape, it can pull the valve out of alignment, causing a functional TR. The valve might be okay, but the muscle isn't supporting it properly.
Okay, and this next one might seem counterintuitive. How can a problem on the left side of the heart cause trouble on the right side, leading to TR?
That's a really important pathway. Pulmonary hypertension and left-sided heart failure. Imagine the left side isn't pumping efficiently, maybe severe mitral valve leakage, another common issue. Pressure backs up, first into the lungs. That's pulmonary hypertension, high blood pressure in the pulmonary arteries. That high pressure puts a huge strain on the right ventricle, which has to pump against it. Over time, the right ventricle gets overworked, enlarges.
Stretching the tricuspid annulus.
Exactly. Stretching the ring, leading to TR. It's a knock-on effect. Left side problem causes lung pressure, causes right side failure. And finally, though less common for the tricuspid valve, you can have ruptured chordae tendineae or papillary muscles. Those heartstrings actually breaking. That's a direct mechanical failure. Leads to sudden, usually severe TR. It happens, but maybe more often with the mitral valve.
So a whole spectrum of causes. Training adaptation, wear and tear, infection, muscle issues, knock-on effects. What happens as this leakage gets worse? Does the horse's body just keep compensating?
Well, it tries. Initially, the heart compensates using something called the Frank-Starling mechanism. Basically, it stretches more to pump harder, trying to handle the extra blood volume sloshing back and forth. But as the regurgitation gets more severe, the heart just can't keep up maintaining good forward blood flow. You get progressive volume overload, the right atrium and ventricle dilate even more, and eventually that leads to right-sided heart failure. That's when the system is really decompensated.
And the signs of that failure sound pretty dramatic.
They can be, yeah. This is when it's definitely not incidental anymore. You see that dependent edema fluid pooling in the legs, under the chest or belly, prominent jugular veins, maybe even pulsing, ascites fluid in the abdomen, an enlarged liver, hepatomegaly, obvious exercise intolerance, significant weight loss, cachexia, sometimes even jaundice, that yellow tinge, increased resting heart rate, respiratory rate, and arrhythmias can kick in too, like atrial fibrillation. AF is the most common serious rhythm issue in horses.
That really paints a clear and, well, concerning picture of what severe TR looks like.
Oh.
Okay, so if you or your vet suspects TR, how do you actually diagnose it? How do you get to the bottom of it? It sounds like it starts with just listening.
Absolutely. The physical exam, and especially auscultation, listening with the stethoscope, that's always the first step, and often it's very informative. The TR murmur, as we said, it's systolic, between the lub and the dupe. You hear it best on the right side of the chest, usually around the third or fourth intercostal space between those ribs. It's often described as plateau-shaped, meaning it's fairly constant intensity and often sounds quite harsh. And here's a really useful clue. The loudness, the grade of the murmur, generally correlates pretty well with how severe the leak actually is.
So a louder murmur usually means a bigger leak.
Typically, yes. And if it's the only systolic murmur you hear clearly on the right side, it's highly suggestive of TR. You do have to differentiate it sometimes, especially from a VSD, a ventricular septal defect, that hole between ventricles. VSDs are more common in certain breeds, like Welsh Section A ponies, Arabians. They might have a murmur elsewhere too, like over the pulmonic valve.
So a good ear tells you a lot.
Yeah.
But it's not the whole story, right? When do you need more? When do the big guns come out?
Right. For the definitive picture, echocardiography is really the gold standard. It's an ultrasound of the heart. Non-invasive, gives you real-time images of the heart structure and function. It's incredibly valuable.
What exactly can you see with an echo?
A lot. First, valve morphology and function. You can actually see the valve leaflets. Are they prolapsing, bulging back? Are they flailing, meaning really loose, maybe because a cord are ruptured? Are there vegetations, those lumpy bits suggesting infective endocarditis? Or just general thickening from degenerative changes? You visualize all that. Second, quantification of the leak. Using color Doppler, you see the regurgitant jet as a colored stream flowing backward. We can estimate its size relative to the right atrium.
You mentioned percentages.
Yeah, it's semi-quantitative, like very small, less than 10% of the atrium area, small, 10-30%, medium, 30-50%, large, over 50%. Gives you a much better idea of severity than just the murmur loudness alone. Third, cardiac chamber dimensions. We measure the right atrium and ventricle precisely. Are they enlarged? That tells you how much the heart is remodeling, how much volume overload there is. We can also see things like paradoxical septal motion, the wall between the ventricles moving abnormally, another sign the right side is overloaded. And fourth, it helps rule out or confirm underlying abnormalities like endocarditis or check for other coexisting heart issues.
So it's way beyond just, is there a leak? It's how bad is it, why is it happening, and how is the heart coping? Okay. Any other tests that might come into play?
Sometimes, yeah. Ancillary tests. Electrocardiography and ECG isn't great for diagnosing TR itself, but it's key for detecting arrhythmias, irregular heart rhythms, that significant right atrial enlargement you get with TR. It makes horses more prone to atrial fibrillation, AF, which, as I said, is a big cause of poor performance. ECG picks that up. And blood tests, mainly if you suspect an underlying infection like endocarditis, looking for signs of inflammation, high white cell counts, that sort of thing.
Got it. So you've done the exam, maybe the echo, you have a diagnosis, TR is confirmed. What's next? What are the treatment options? Can you actually fix this leaky valve?
Right, the treatment path. Here's another really important takeaway. Treatment depends almost entirely on severity and whether there are clinical signs, especially heart failure signs. And the good news is most horses with mild, maybe even moderate TR, they often need no treatment at all.
Really? No treatment?
Often, yes. They can frequently continue in full work, full athletic careers, as long as the leak isn't severe and they aren't showing exercise intolerance or signs of heart failure. Now, for the severe cases or when heart failure signs do appear, then we move to medical management.
Okay, what does that involve?
Primarily managing the fluid overload and reducing the heart's workload. So diuretics like furosemide Lasix is a common brand name. Powerful drug to help them pee out excess fluid, reduce edema and effusions. We might use vasodilators, drugs that relax blood vessels. ACE inhibitors like benazepril are sometimes used, though maybe with only marginal effect in horses, according to some sources. Often used alongside diuretics. If the heart muscle itself is really weak, we might consider positive inotropes like digoxin or dobutamine to help it contract more forcefully. But these need really careful monitoring risk of causing arrhythmias.
Right, tricky balance.
Very. And if there is a concurrent arrhythmia like AF, then antiarrhythmic drugs like quinidine might be used. But again, quinidine has a narrow safety margin, lots of potential side effects in horses, needs expert handling, and absolutely critical. If it's infective endocarditis, then aggressive long-term antimicrobial therapy is essential to try and clear the infection. But maybe the overarching principle is treating any primary underlying condition. If the TR is secondary to left-sided failure, you treat the left side. If it's myocarditis, you address that. Treating the root cause is key.
That covers the medical side thoroughly. But what about surgery? In humans, valve surgery is common. Can we just replace the valve in a horse?
Surgery. Well, in theory, procedures like valve repair or annuloplasty tightening that stress string or even full valve replacement, they exist as concepts. But, and this is a big but, surgical options for heart valve disease in horses are still highly uncommon and really challenging in veterinary practice. It's not like human medicine at all in this regard.
Why is that? Just the size?
Size is a huge factor, yes. But also the risks of general anesthesia in a large horse for such a long, complex procedure. You need incredibly specialized equipment, bypass machines scaled for horses. The surgery itself is technically demanding, and the post-operative care required is intensive and expensive. Most equine hospitals just aren't set up for it, and frankly, it's often not economically viable for owners.
So practically speaking, surgery is rarely on the table for equine TR.
Very rarely. Medical management is almost always the focus.
Okay, that brings us to the outlook. What is the prognosis for a horse diagnosed with TR? Does it mean their career is over? What about their lifespan?
It's really, really variable. It completely depends on the severity, the underlying cause, and whether complications like heart failure have developed. For horses with just trace or mild TR, particularly that physiologic TR in athletes, the outlook is often excellent. Normal performance, normal life expectancy. The leak might not even change for years. That's probably the most common scenario you'll encounter.
That's reassuring for many owners.
It is. But the picture changes if the cause is more serious, like a ruptured chorda or a flail leaflet or infective endocarditis. In those cases, the prognosis is usually more guarded to poor because the regurgitation tends to get progressively worse. And if a horse develops congestive heart failure because of severe valve disease, the prognosis for life becomes guarded to grave. Even with treatment, sadly, many are euthanized within, say, 2 to 6 months, although some might show temporary improvement.
And performance-wise.
Mild to moderate TR, as we said, typically doesn't affect performance, but severe TR, that will lead to poor athletic performance, reduced exercise tolerance, and definitely a shortened life expectancy. Those horses really shouldn't be in work, certainly not strenuous work.
So it sounds like regular monitoring is key, especially if it's more than just mild.
Absolutely. The recommendation is generally for annual echocardiograms, those heart ultrasounds for horses with moderate to severe TR, just to track any changes, see if things are progressing, and adjust management if needed.
We have covered a lot of ground today. A real deep dive into equine tricuspid regurgitation. It's clear this condition exists on a huge spectrum, doesn't it? From something you might just note down in an exam on a top athlete,
To something that requires significant medical intervention and signals a very serious heart problem.
and we've seen how crucial diagnostics are, particularly echo, for really understanding what's going on, the severity, the cause, which then guides how you manage it, even if surgery isn't usually an option.
Exactly. It's not just about hearing that whoosh sound. It's about figuring out what that whoosh means for that specific horse in their specific situation.
So what does this mean for you, listening? Well, hopefully understanding these nuances helps you appreciate the incredible way these animals function, how their bodies adapt, and maybe helps you have better conversations with your vet. It also highlights that normal for a high-performance athlete might look a little different, sometimes involving these subtle cardiac adaptations that need monitoring, but aren't necessarily career-ending. And that brings us to your final thought to chew on. Given how often TR in athletic horses is seen as this physiological adaptation, what does that really tell us about where we draw the line between pushing performance limits and recognizing early pathological changes? That applies to any athlete, really, equine or human. How do we know when an adaptation crosses over into being a problem? And are we truly understanding the risks we accept in pursuit of peak performance? Something to think about. Thanks for joining us for this deep dive. We'll be back next time to tackle another stack of your sources.